Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. I'm your co-host, Ali Khan Lalani, joined by my co-host, Christopher Wallis. We are live September 16th at ESMO 2024 in the El Raval region here in Barcelona. Chris, it's good to be back after a summer. How are you feeling, man?
It's good. It's nice to be back to the science, back to seeing some colleagues and friends at the meeting. And, we've been hearing word on the street around Barcelona is that people have been missing out on their View on GU episodes. So it's good to be back to making some content.
Got to give the people what they want. So let's start today with prostate. We're going to, really break this down into the disease spaces. So we'll start with really key take-home data for mCSPC, or the brand new stage for prostate cancer, and then transition to the important findings we had for mCRPC or hormone-resistant prostate cancer. So, Chris, why don't we kick it off with ARANOTE, looking at ADT plus another ARPI in the mCSPC setting.
Absolutely. We had some great Canadian representation here at ESMO this year. And so Fred Saad presented this morning results of the ARANOTE trial. And this is, pretty eagerly awaited, I would say. We've been all sort of anticipating this data coming out, and so it's nice to finally see it. So just to reiterate, ARANOTE falls in the sort of pattern of many other trials we've seen in the mCSPC or mHSPC disease space, where we have the addition of an androgen receptor pathway inhibitor to an ADT backbone for de novo disease. And so here we obviously are adding darolutamide at our standard doses, 600 twice a day, to an ADT backbone. I think when we look across the trials, there's a few interesting things that are worth highlighting for ARANOTE. Number one, because of registrational reasons, it's an ex-US study, but it's a very well representing the global landscape, I think. It captures a wide swath of the world and importantly represents underrepresented patient populations. And so we have like 30% Asian population. We have like a 10% Black population. And so, these are populations that in general are underrepresented in prostate cancer trials, which are predominantly Caucasian dominated. And so I think that's an important comment on the generalizability of these data. And they really, I think, are important and impactful in that way. And so, this, like ARCHES, was a trial designed around an RPFS endpoint. Obviously, OS is an important secondary endpoint, but this study is really designed and powered around the RPFS endpoint, and it met its target. It met its primary outcome with an RPFS benefit of 46%. That's a hazard ratio 0.54. Obviously, very statistically significant and meaningful differences. So you get benchmark 2-year differences exceeding 20%. And I think that's, a really meaningful magnitude of benefit. Obviously, in a trial that's designed around RPFS, first report of OS data is always going to come out immature. Mm-hmm. And so I don't think we're surprised to see that the OS data is not mature and doesn't really show a statistically significant benefit. We do see, the right direction of benefit and a hazard ratio around 0.8. But I think importantly supporting that RPFS benefit, in spite of the lack of OS, is other important metrics. And so we have, time to metastatic castration-resistant disease. We have time to pain progression. Those are favoring the addition of darolutamide, and I really think speaks to an overall clinical benefit for this agent. Now, obviously, there's the question of where it fits in the greater context.
Yeah, no, it's a good point. And I like what you said that, firstly, to be the later of the ARPI ADT trials being reported, what can be added. So I think that population, as you said, 30% Asian and 10% Black population is important. A significant number, high volume, 70%. And not surprisingly that the medians for OS for either high or low volume aren't reached. In the larger context, and our listeners and viewers will know, but, we've had Enzamet with enzalutamide. We've had ARCHES readout, we've had Titan, Latitude, and obviously Stampede. So we've had a whole swath of these ARPI or ARAT type studies. I mean, overall, I think the PFS, median not being reached, a hazard ratio of 0.54, maybe a little bit north of where we'd seen other hazard ratios, but again, early. And I do think when we look at these types of trials, we would want to have a survival signal, and we want to see that to really influence how this becomes kind of registered and used. So seeing the point estimate right now at 0.81, again, early, not a lot of events yet. Just to remind folks, basically all the other studies, even including docetaxel with ADT in the charted study, essentially for the studied populations, largely hazard ratios of 0.65, 0.66, 0.67. So I think we're going to want to see that migrate into that range, as we would expect for darolutamide. Some obvious advantages, I wonder, Chris, from a urologic oncology standpoint, these patients show up with mCSPC oftentimes to a urologist. Where would you put this in the context of what's available? So for those who are in Canada having, and around the world having generic abiraterone now after many years, apalutamide, enzalutamide is available. Let's say you were to add darolutamide to your toolbox with a pending registration at some point. As a uro-oncologist, what do you make of it? And how would you really put this into the armament you can use for your patients?
Absolutely. I think it's a great question. I think our discussant raised it a little bit that in certain aspects or areas of the world, depending on sort of HTA assessment, there may be some barriers to access here. But I think it does represent an important tool for us. I think there's a couple of things to consider. I think it's a bit easier probably to prescribe and manage. Certainly DDIs are a feature. We know that both enzalutamide and apalutamide have sometimes difficult to manage DDIs, particularly around the DOACs and the need for anticoagulation in many of our 60, 70, 80-year-old men. Like it's a common thing. And so I think when we think about rolling this out, we know that there's been issues with uptake of use of ARPIs in our community, and it hasn't been as widely adopted as we would hope. And so I think anything that we can bring to the table that reduces that barrier to access and makes people who are maybe not prescribing today a little more comfortable with the idea of prescribing is certainly beneficial. I think from a purely logistic perspective, it maybe opens up ease of access to triplet a little bit. Right now, certainly with the way approvals are, if you're open to the idea of triplet or you think it may be appropriate for your patient, you need to get them in to see a med-onc before you start your ARPI. This opens the possibility where you can start ADT, start Daro, and then send off for a med-onc opinion about the appropriateness of some docetaxel as a triplet, and it keeps that door open. And so I think there's certain features that are going to help facilitate urologists getting a little bit better treatment intensification to our patients.
Yeah. I mean, it's a good point about the triplet. I mean, in fairness, one could argue and say, well, abiraterone in many places is now, a public drug benefit depending on where you're at. So we can start that and get the chemo going. But you are right. We do need more of those kind of seamless transitions. I mean, I do think all these options, we're fortunate in Canada that we do have access to these, and obviously keen to have darolutamide as well. I guess the points I would make would be, beyond the age-old kind of beating of the drum of intensifying patients, which we need to do. I think we all agree on that. It's still important, no matter what you're using, to understand drug-drug interactions. I think you're right. The outpatient setting in a community urologic shingle, let's say, versus somebody who's seeing someone in an academic center, access to pharmacy and DDI reviews is variable. So we do need to consider those. I'm thinking about CYP3A4, CYP2C8, all these other drugs that might inhibit or induce these types of pathways is important. And then all these studies we're talking about today with these drugs working in stage 4 disease are moving up to the high risk localized or localized settings, even maybe intermediate risk in the future. So how we understand to use these drugs and have availability is really important. So I think, we've done well. We need to do better. And I think having more multi-D care in this space is going to be important. I envision a future where it's radiation oncologists giving these medications. I think uro-oncologists in many places, certainly where you're at, where I'm at, we're quite fortunate. We have an active urologic oncology group to give these drugs. So many people being comfortable with not just prescribing but how to manage and navigate the concomitant meds will be huge. So I think it's valuable data. I'm glad we started with that.
For sure. I think we saw, other ways to intensify in mCSPC. I think we've all bought the idea that it needs to be done, and now it's a debate about how it's done. So maybe you want to take us through upfront PSMA and look at early data on the role of radioligand therapy in this space.
Yeah, no, great. Another really wonderful, I would say, addition by the Australian group, this time led by principal investigators Dr. Arun Azad and Michael Hoffman. A phase 2 study, just to level set. This was a randomized study for patients who would have been early on in diagnosis, a PSA at least of 10, and had started ADT, but up to 4 weeks on ADT. So again, being seen quite well. These patients would have undergone PSMA PET and FDG PET imaging with central review, which is quite important, and to make sure really there's no major discordance. Okay, so if we assume those patients then are met without major discordance, they would have been randomized to get in the mCSPC setting, docetaxel, usual dose and schedule for 6 cycles, or starting with lutetium and again PSMA 617 at the 7.5 gigabicral dose for 2 cycles. So 2 cycles of that, and then sequentially going on to the docetaxel for 6 cycles. And really their top line data in terms of findings had an undetectable PSA rate. So, randomized phase 2 trial looking at undetectable PSA rates at 1 year, 41% with the lutetium for 2 cycles and then chemo versus 16% in the chemo alone. PSA progression-free survival was 30 months versus 21 months. And then looking at radiographic progression-free survival hazard ratio of 0.58 with the median in lutetium not reached 22 months in the chemo alone arms. Some grade 3 to 4 adverse events felt to be usually attributable to the chemotherapy. And I think, that would be fair to say. And, really this was an important, I think, overall data to really, as you say, start to get us to the next level of treatment intensification.
Mm-hmm.
This is now adding lutetium to chemotherapy. Again, I think comments were well made as to why was it things like 2 lutetium administrations. Part of that might have been not delaying the time to get chemotherapy because, really that's an important standard of care at that time. And there's some, financial and other logistical considerations as how much lutetium can you give in a study of this type, really led in an academic way. So I think, again, these are really randomized data in a de novo high volume setting. I think the endpoint is undetectable PSA in general in prostate cancer, particularly for mCSPC. We're looking at overall survival. So we are having other studies that will look at answering this. PSMA addition, for example, a phase 3 trial we had at our site, looking at adding lutetium to a really standard of care. But, really it could implicate what we do in the field, but larger theme of let's do better for mCSPC.
Mm-hmm.
I wonder what you think of that as a uro-oncologist, that maybe in the future for MCS, we might even have a referral, not just for consideration of triplet, but maybe for even getting, radioligand therapy up front.
Well, I think it's a really exciting possibility. I think as soon as we saw Vision reading out, everyone was thinking about how early can this migrate. And I think when we're conceptualizing the treatment paradigm, I think arguably PSMA addition makes a bit more sense to me. Right, we're adding docetaxel in a cytotoxic way to like radiotherapy, which is trying to be cytotoxic right now. And so a multiple mechanism of action approach, adding the radioligand to an androgen receptor-based backbone may even bring us further. And I think we've certainly seen that, adding the ARPI to a DOSI backbone offers some benefit. And so, I think we're moving the needle. I don't think we're going to be adopting this treatment paradigm in the near future, and maybe not at all. It may just be a sort of transitory academic contribution that leads us down the line of using lutetium earlier in the disease space rather than using this specific regime, because as you alluded to, the control arm now is a little outdated, I would say, but certainly an important conceptual contribution on moving us earlier and earlier in the disease space with lutetium.
So that's a great segue into, I think, the next major abstract. Let's stick on the radionucleotide theme, Chris, let's look at lutetium in the mCRPC setting. We've had other data at almost every Congress, and now we are seeing the kind of top line results in a presented form by Splash. So maybe take us through the Splash study.
Absolutely. So I think we've been waiting on this trial for close to a year now. Every time we hear that Oliver Sartor is going to get up, and then we're just kept on our toes, I suppose. So Splash, follows a study design that's very sort of familiar to us, I would say. In the ARPI pre-treated mCRPC, importantly here, not docetaxel exposed, patients were randomized to either receive lutetium or to receive an ARPI switch. And now there's lots of discussion about the ARPI switch. And that conversation dates back to Profound probably and earlier. But importantly, I would say in this study, the crossover rate was high. So patients who got the ARPI switch at the time of adjudicated progression were offered lutetium, and they were actually receiving it at very high rates, like 85% of patients. So to me, this is a study that really asks the question, is it better to get lutetium a bit earlier or a little bit later? It's not about lutetium, yes, no. It's about timing of lutetium, really. I think it's important to point out that Splash uses a different molecule than we've typically been used to. It's not PSMA 617. It's PSMA INT or 2002, depending on your terminology you prefer. And so there's both a different molecule, but arguably more importantly, different dosing and dosimetry. So you just alluded to it for upfront PSMA, where the dose used is 7.4 gigabecquerel. Here we're talking about 6.8, and this is Q8-week dosing up to 4 cycles. That means that when we put it in context with the equivalent study PSMA4, we're talking somewhere between 30 or 40% less dose administered in Splash than we've seen in other lutetium-based trials. And I think that's important to level set and understand the amount of dose administered. And so with that said, the primary endpoint that was reported here is RPFS. We have a significantly improved radiographic progression-free survival for patients receiving lutetium. Hazard ratio is 0.71, so that's a 29% reduction. Medians improve, appropriately from about 6 out to 9.5. That's what we're, I think, expecting or hoping. Overall, it's pretty well tolerated, I would say. But interestingly, we don't see massive differences, I would say, in toxicity compared to the higher dose regimes we've seen in other trials. And then obviously the closing point is that OS data here is not ready, not yet ready for prime time. Although arguably when we saw PSMA4 in the same way, we did not see significant OS survival benefits.
Yeah, I mean, no, all good points. I mean, still about screening patients with MCR, had an ARPI in these trials, having whereas other studies would have had the assessing of concordance or not. Here, having PSMA avid PET, but no FDG PETs in some of these studies in the similar landscape. Again, allowing taxane, but as you said, had to be more than 1 year out. And then this was a 2-to-1 randomization. I agree with you. At a back of a room or paper napkin approach, I mean, you're getting up to 27.2 gigabecquerels in Splash versus other trials might have been 44-ish in the range. And again, the dosing and schedule is important. Comments that it was FDA mandated. How will other studies that try to build on this move forward? I mean, my take is that it's great. Obviously, the disclosure here is we have some good Canadian contribution in terms of thought, design, and execution. So that's nice to see. I think as not to speculate too much, but if you're looking at further studies, I do think that dose and schedule does need to be just really optimized, ideally, and then the larger piece will be getting OS, because for mCRPC, I think we really do expect as a field, as our feet has kind of voted that we want to see OS. And, it'll be really important. I'm sure HTAs will say, how do we become competitive with all these agents? Because I think one of the comments we probably should make, Chris, is as we're recording this, many jurisdictions still don't have lutetium widely available and reimbursed in their jurisdictions for the MCR post-ARAT post taxane.
Yeah, the vision indication.
So truly post MCR treatment as we would contemporarily feel with both an ARAT and a taxane in that setting, to then be able to avail of lutetium routinely in clinical practice, right? Outside of privileged centers or patients who can pay. So I hope maybe by the time this comes out, or maybe in a few weeks, we can addend this to say, well, we've added another country, let's say, to reimbursement. But that is, I think, the larger piece, because then it becomes, can we use some of the innovative data? How does PSMA PET means imaging uptake relate to ctDNA, which we're talking about, and we'll talk about in other cancers. But there's perhaps last time we saw a little bit of an inverse relationship by some of the data presented at ASCO. It's very hard in the real world to accumulate this data if we don't have lutetium widely available. So I think it'll be nice, having done these trials, to have it reimbursed. So I agree with you, really nice addition to the radioligand story. But the radiopharmaceutical story, so to speak, is still ongoing in MCR as we transition to our last abstract that we'll focus on today, and that's piece 3.
Presidential, which is always lovely to see GU up on the stage there.
Yeah, we had 2 of them. Our first one that we'll cover today, as mentioned, piece 3, presented by Professor Gillison. And very quickly, this was an EORTC a study, patients with MCR having obviously bone metastasis, but by definition being asymptomatic or mildly symptomatic, were essentially randomized to getting radium, which is available, certainly in many countries. It is available in Ontario, not I would say equivalently across Canada is a fair comment, but radium that many of us do use every 4 weeks for 6 cycles, plus ENZA standard dose, 160 milligrams, randomized against a control arm of enzalutamide. Now, again, importantly, these are mCRPC patients that would not have had significantly ARAT prior. Some patients did get on with prior abiraterone, but this was 2%. Docetaxel was allowed, which was around 30%, given that they could have had that chemo in the mCSPC setting. So that was nice to see. But these patients were, followed in a randomized study with a primary endpoint of rPFS. And I think, top line data wise, ENZA plus radium had an improvement in the rPFS median of 19 versus 16 months. That's a hazard ratio of about 0.69. In terms of overall survival, admittedly an interim analysis, so this is where we can get into it, ENZA at around 35 months, which, in a first treatment for MCR setting at 35 months, we've seen this number before. So that does give us some comfort. And then up to 42 months with the ENZA plus radium, again, hazard ratio of 0.69. Now, comments here is that at the early part of the curve, ENZA was a little bit higher up and then crossed. And so this kind of violates Cox proportional hazards. And so using log rank tests, statistical, I guess, faux pas, but we will have longer follow-up for that. I think that's very important. One of my takeaways, though, was a really important slide, and I want to get your take on this, because I think the multi-D setting, we need to learn from this point. And that was, when you dig into time to a symptomatic skeletal event, that wasn't distinctly different in either arm, because there were some thoughts that maybe that would be an issue, as we'd seen in radium plus abiraterone data. But importantly here, there was an adjustment or amendment along the way to mandate BPAs, or bone protective agents, to the point where it got beyond 80% in both arms in a mCRPC trial. So, you wonder which of these patients that might have unfortunately experienced an early survival event might not have had a bone protective agent. So, obviously, as we wait, Chris, on this trial for OS, we like to see the rPFS. And it's, again, in the nice, convenient bin of never having had an ARAT. Maybe your take on where you see radium as let's say a uro-oncologist who might be referred these patients who've never had it, now referring to get someone who might get radium. And then the general comment on the field about bone protective agents, because for me, I think that's the larger theme.
For sure. I think there's 2 real takeaways here. And so number one, on the bone protective agent angle, obviously we saw the ERA 223 data, right? And that's what prompted this amendment. So the combination of Abi and radium really increased SREs. And so if you look at the first, 120 patients or so on this trial, bone protective agents weren't mandated. And we saw really high SRE events. In the ENZA only arm, we're thinking like 25% at 2 years and up to nearly 50% at 2 years in the combo arm. So that radium combination was driving higher rates of SREs before the bone protective agents were added. And when they were added in both arms, the rates dropped to like less than 5%. So it really highlights the fact that, if you're appropriately prophylaxing for skeletal-related events, the addition of radium doesn't cause added toxicity, but it's just this overall patient population deserves to get bone protective agents. The real question, I guess, is going to become duration and things like that. Are we doing 2-3 years? Are we doing indefinite? But I think that's one key takeaway. The other thing I think it's important when we think about the registrational studies for radium is that Alsimca was in a symptomatic patient population, and this was an asymptomatic patient population. So it maybe opens up a little bit the population we would consider where radium to be relevant for. Obviously, there's the issues we talked about before that most patients coming to mCRPC should be pretreated. They should have seen an ARPI before they get there. And so, arguably this data isn't directly applicable, but we know that out in our communities, there's lots of patients who are arriving at first-line mCRPC without having seen anything but ADT. So I think, as we move forward, this is a relevant treatment paradigm. Hopefully over time, it becomes less relevant. And I think, it's even in that context still a good contribution to our understanding of how we can combine therapies.
Yeah, I mean, totally. The point made about the fracture rate now at grade 3 fracture higher of 5% with the two drugs together, I think is important to see. But it when you zoom out and say, well, I may or may not have a lot of these patients in my clinic, I think the data shows they exist, whether it's community in Canada, US, or around the world, these untreated patients. I think the conundrum is going to be if someone, for whatever reason, wasn't treated with an ARAT, shows up mCRPC without an ARAT, is that person fit to now get radium plus an ARAT? Are they going to be in a clinical context where they'll be referred at that point to consider radium versus just added on to an ARAT? And then the third piece is, irrespective of this data, I think it just reinforces we really need to elevate our game for bone protective agent, at least in the mCRPC. I think irrespective of what you're coming off of or starting on. So I really encourage, I think this is where the community can come together. Academic clinicians, clinicians who are more kind of community-based, our allied healthcare teams, and even industry to say, okay, let's just, enough now, let's elevate our game. Let's make our bone protective agent game, irrespective of where you work, much more accessible and used, because then treatments like this can be, I think, done safely, because you can see that there is a difference when it was done in the AbbVie setting and in the ENZA setting. Is it really the ARAT, or is it more likely the supportive medications around that? So kind of a pitch as to really a takeaway for those in the community. But yeah, I mean, we could have covered so much more. There was a radium versus DOSI sequencing study that was presented. I think we kind of are still waiting for their primary endpoint and further follow-up. So there's still important questions. I think, to your point, these are patients by definition that don't have liver mets or lots of visceral metastatic disease. They need to be asymptomatic or mildly symptomatic. So using radium earlier probably makes the most sense. And yeah, I think that wraps up a really nice prostate day. There's so much more we could go over, but I think this was really the key take home. So to our listeners and viewers, I wanted to thank them for joining us. We have episodes coming on bladder cancer and renal cancer, so don't forget to rate, review, and subscribe. And for Chris and I, thank you for watching.